you for joining our webinar. This is the Robert Wood Johnson Foundation Systems for Action Research Program in our regularly recurring Research in Progress webinar series. If you are new to Systems for Action, or at least new to this webinar series, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. Our mission is to study innovative ways of connecting medical, social, and public health delivery systems in ways that can improve health and health equity. Through this program, we fund a whole variety of studies, rigorously testing ways of connecting and aligning systems. And about every 2 weeks, we feature one of those studies in this webinar series. This webinar series is open to anybody who's interested in learning about how to help medical and social public health systems work better together. As we always do, we're glad to feature one of our research teams. This gives our research teams a chance to share with you emerging findings and lessons learned from their study, what they're learning about what works and what doesn't work in terms of helping systems to align and work together. We're very excited today to feature a research team studying ways of connecting vulnerable seniors to nutrition assistance through a managed care plan. And I think you can go to the next slide. So you see the names of our presenters today. Like most of our research team, this is a multi-organizational and interdisciplinary research team. We have leaders from 2 organizations with us, Benefits Data Trust, collaborating with University of Pittsburgh Medical Center, UPMC Center for High Value Healthcare, to conduct this study. So we will, just in terms of logistics, we'll first hear from our research team. They'll step us through our study and what they're learning. Toward the latter part of the hour, we should have ample time for questions and answers from our participants, audience members today. We are on Zoom, and we do have a pretty large group of attendees with us today. So we're going to ask you to type your questions into the Q&A box, which, if you're with us on Zoom, you should see an icon down at the lower center of your screen labeled Q&A. Click on that at any time during the presentation, type your question in. We'll get to as many of those questions as we can during the latter part of today's hour. Do also want to let everybody know we do record these webinar sessions, and we post the recordings on the Systems for Action website for any of your colleagues who may not be able to be with us live today, and we'll also post copies of the slides as well. So with that, let's go to the next slide. I think we have some bios here featured from our members of the research team that'll be with us today. We'll starting off with Ashley Humeni, who is Director of Healthcare Innovation at Benefits Data Trust. And I think next slide, you'll see a couple of our other speakers. Dr. Joan Etchner, who is with the UPMC Center for Social Impact. And also Dr. Elaine Kwok, who is a health services researcher, also at the UPMC Center for High Value Healthcare. So with that, and I can say I'm your moderator today. I'm Glenn Mays. I'm at the University of Colorado, which is the home base for the Systems for Action Research Program. Our national program office for this program is based here, and so I'll also be moderating the Q&A when we get to that portion of today's webinar. So with that, I'm going to turn it over to Ashley and team to get us started.
Hi, thanks, Glenn. Good morning, good afternoon, everyone. Like Glenn said, I'm Ashley Humeni. I lead our partnerships with healthcare here at BDT. I feel like I should also introduce Peggy the dog. We are doing some emergency pet sitting today, so you might see her. We're keeping some dogs separate, so I apologize in advance. But she's pretty cute, cuter than I am. So if you do see her, say hi. So I'll go into a little bit of what BDT is. We are a national nonprofit that has a pretty singular focus, which is connecting people who are eligible for a myriad of public benefit programs, such as SNAP, such as WIC, helping them recertify for Medicaid, heating assistance, healthcare coverage, or prescription assistance. We're connecting those who are eligible with the benefits themselves. Why we do this, those benefits have been proven to be a really demonstrable way to better health, lower healthcare costs, and just overall better well-being. So there has been research that's come out in the past 5 years, more and more, demonstrating the impact that SNAP can have on someone's health and overall healthcare costs in the system. Direct service is the foundation of our work. We started out as a small call center. I was actually on the phones when I was 19 and interning at BDT, helping people apply for Part D low-income subsidy, also known as extra help. And we've grown since then to a contact center of over 160 folks on the phones every day, helping people, helping screen people for different benefits and submitting those benefits applications on their behalf if we can. In the time that we've been around, we've helped people submit more than 1.2 million benefit applications. So we work with healthcare. It's a way we can superpower our efforts to get folks connected to dollars to help with food, heat, rent, health coverage. UPMC was our first partner in the healthcare space. They're our favorite partner, but don't tell anyone else here that I said that. They have such a fantastic team, and they're really super focused on how to improve the overall connection of their members to things that can help with their social needs. Next slide, please. Thanks, Elaine. So the overall, this also shows the need for BDT, and it is the reason why we exist, is that there is a huge access gap to these benefits. More than $80 billion in these the value of these benefits goes untapped nationally at any given time. We actually estimated that it was 60 billion last year, and this comes from a range of both government and trusted private data sources. It went from 60 to 80 billion because of the introduction of the Affordable Connectivity Program, which helps people afford broadband assistance, which is great. So this really shows the scale of the problem and the fact that there is a need for a solution that can scale. We know from data that about 40% of Medicaid recipients in the state of Pennsylvania are not receiving SNAP. Most of those folks should be on SNAP. And we know this is similar in many other states. So this is kind of the size of the problem that we're hoping to address. Next slide, please. Thanks. So I know everyone here probably knows how difficult it is to apply for a lot of these programs, such as SNAP. Going actually through the step-by-step process and seeing the barriers along every step is something that BDT really focuses on each specific challenge and tries to create a really good customer service experience around helping someone actually apply and get enrolled. So we're battling barriers like lack of awareness around eligibility, confusing applications. In certain states, the SNAP application can be more than 20 pages. Interviews for those benefits before someone is enrolled often happen, and those are tough to schedule and attend. And there is a lot of follow-up to applications, often in the form of documentations or other types of verification. Something that's not on this slide that plays a huge part, especially with seniors who are the population we're going to talk about today, stigma. So questions around, am I taking this money from someone else? I don't really need this benefit. That is something that is also a big reason why there's under enrollment, especially among folks 65 plus in the US. So that's something that all of these barriers, we've kind of built a model around addressing each one. Next slide, please. So the model that we do have is the direct assistance piece that I was talking about. BDT, in the past 10 years or so, we've grown to have a fantastic policy team, a team building digital tools to help with self-screening or assisted screening. We also have a fantastic data and analytics team, the research team that our lead for our research department is on the webinar here, Lisa Dillman. So it's really fantastic, but we've never lost sight of our core service, which is helping people directly. So once someone receives a outreach from us, be that through mail, text message, email, or maybe someone is warm transferred to us, the goal is to really provide as dignified and comprehensive as an experience as possible to that person in helping them screening them for multiple benefits at once. And if they're determined as likely eligible, we'll fill out the application with them on the phone and submit it on their behalf if we can. Again, we're working on a large scale, so we're submitting tens of thousands of applications every year. Pennsylvania is our home state. We're based in Philadelphia and we've worked in Pennsylvania the longest. So all the more appropriate that UPMC is our first healthcare partner. The work that we did with UPMC for this research project, which Joan and Elaine will get into it a little bit more, is helping UPMC dual eligibles access SNAP and other benefits. So that means folks who are UPMC members who we outreach to that are likely not enrolled for those benefits, and really helping them access those. So that, I think I am now turning it over to the UPMC team.
Thanks, Ashley. So hi, everyone. I'm Joan Eichner, and I'm representing the UPMC Center for High Value Healthcare along with Elaine. So let me give you a little background briefly on UPMC. We are an integrated payer provider healthcare system and academic medical center that's headquartered in Pittsburgh, Pennsylvania. We have over 35 hospitals, over 800 outpatient provider partners, and we cover over 4 million lives through physical and/or behavioral health insurance products. The Center for High Value Healthcare is a unique entity within a healthcare payer environment. We've been around since 2011 as a nonprofit research organization. We exist to leverage the payer provider environment to create real world studies where we can look at enhancing efficiency, quality, and the patient experience, as well as the provider experience through different comparative effectiveness studies and other externally funded research collaborations, as well as internal innovations and evaluations where we are able to essentially leverage the integrated data that we have to really test different innovations in the payer provider space. And then we try to broadly disseminate these findings, both within the healthcare and then moving more into the social services space as well, in response to increasing social determinants of health needs. Next slide, please, Elaine. So I want to give a background on sort of our population for this study, which is the Community Health Choices population. Community Health Choices was rolled out starting in 2018 in Pennsylvania. This is the Pennsylvania Department of Human Services program to offer Medicaid assistance or medical assistance to dual eligible individuals, Medicaid and Medicare eligible individuals who are typically older persons, individuals living with disabilities, and those who are eligible for long-term services and supports either in a home and community-based setting or within a skilled nursing facility. Next slide, please, Elaine. Thank you. Community Health Choices, or CHC, as we call it, rolled out, as I mentioned, in 2018, over 3 years in a phased approach in Pennsylvania. So the first section was Southwest, where testing your geography here, where Pittsburgh is located. The second phase was phase 2, where Philadelphia is located in the dark blue color. And then what we sort of optimistically call the T, which is this lighter blue area that sort of approximates a T, which is the rest of the state, which rolled out in the third phase. So we took the opportunity to essentially leverage this national experiment that was being rolled out when we were beginning our discussions with BDT to really think about how we could use this opportunity to look at SNAP enrollment assistance in the dual eligible population. That is, as Ashley mentioned, a population of interest to UPMC in particular because they tend to be an older, relatively sicker or more challenged population that's living with a lot of chronic health conditions. And they are a challenging population from a payer side to manage. There's a lot of care there, and there's a lot of value to be added in managing that care in an aligned manner and doing that efficiently and effectively for the member and patient. So just as background, UPMC does cover both fully aligned dual eligibles, which means we would cover their healthcare and their long-term services and supports, in addition to those that are only partially aligned, which means we just do their healthcare payments, while another MCO would cover the long-term services and supports. Next slide, please, Elaine. So why were we interested in looking at SNAP enrollment from the healthcare payer perspective? So again, as Ashley mentioned, and as others will talk about, there's a growing evidence base for why SNAP benefits and why other types of nutrition assistance programs provide physical and behavioral health benefits. So here's just some high points extrapolated from the literature. We know food insecurity in the US as optimistically around 10% of the total population at any given time. During the pandemic, that number increased significantly, especially in the early days. And food insecurity is also much higher in populations that are non-whites, as well as in young children and older adults, and those living with chronic health conditions as well. There are a number of different physiological linkages between poor diet, such as greater access to less expensive energy dense foods, which are not as nutritious and may run counter to a doctor prescribed condition specific diet that's recommended. So SNAP is really a great benefit because it supplements the food budget in a household and is meant to increase access to healthier foods for lower income individuals. So some of the research evidence out there has shown that SNAP enrollment leads to reduced emergency room visits, inpatient hospitalizations, the length of a hospital stay, and as well as reduced long-term care or nursing home admissions, especially among those that are living with chronic health conditions. There is also some evidence that SNAP benefits may lead to improved medication adherence. So all of these things are obviously very good for a member or a patient to stay out of the ED, to stay out of a nursing facility, to have lower healthcare costs. And they're also good from the payer perspective. We want people to be seeking preventive care and managing their healthcare conditions, managing their medications, and not ending up in an emergency room in a treatment situation. We want to be about prevention and maintenance of those healthcare conditions. So this project came together really to hit on a lot of different needs from the healthcare system side, as well as an opportunity to really work with a high quality community-based organization like BDT that had expertise in this space. Next slide, please, Elaine. Thanks. So again, starting in 2018, BDT and UPMC began to formalize their partnership and come up with some ideas for this research study. So we decided that, we wanted to explore and try to rigorously evaluate the impact of a community-based organization and healthcare partnership to address social needs. So we decided that we would, take advantage of the opportunity of the CHC rollout to identify our members who are dual eligible and eligible for receiving SNAP benefits, but not currently enrolled in them. We did this through a somewhat complicated data sharing arrangement between UPMC, the State Department of Human Services, and BDT. And then we would contract with BDT to conduct targeted outreach to those individuals who were not enrolled in SNAP, and provide them with comprehensive application assistance. And then UPMC would receive a confirmation back from Pennsylvania Department of Human Services on who ultimately was enrolled in SNAP to begin to assess outcomes. Next slide, please, Elaine. Thanks. So our original research design, again, involved this quasi-experimental waitlist outreach design. 66% of CHC members were going to be randomized to an immediate outreach. That's our intervention group as conceptualized. And then the last third were going to be randomized to a delayed outreach, which would become the comparison group. Our primary independent variable is SNAP enrollment, and then our primary outcome of interest was hospital utilization within the 12 months after SNAP enrollment. However, we were also interested in exploring some other key metrics of utilization, such as emergency department use, and then cost outcomes associated with planned and unplanned healthcare use. As well as all the costs around medical and total cost of care, et cetera, that typically a payer would look at. Next slide, please, Elaine. So how this originally was conceptualized, again, there were data sharing agreements already in place between BDT and the Department of Human Services, as well as Department of Human Services and UPMC. And so we had to navigate a number of challenges in that way just to have the data flow the way we needed it to for the study. But UPMC would identify our community health choices members, send that list to BDT. BDT would send those names to Department of Human Services that would remove those already enrolled in SNAP, which was not something that UPMC knew at that time, although that has since changed since the start of the study. BDT would then randomize those individuals to the immediate or delayed outreach groups, and then send the outreach lists back to UPMC so that we understood who the treatment group was. For various nuances of data sharing that we don't need to get into here, we were going to have to recreate the comparison group because there was sort of a data disclosure issue that became challenging. But then we could confirm who ultimately enrolled in SNAP through the Pennsylvania Department of PADHS sending us that data back. So this was the ideal plan at the beginning, and we will, we could touch on a little bit more of some of the real world challenges we encountered. Those of you who are paying attention would have noticed that the pandemic happened in the middle of our study, which threw several wrenches into what our original plans were, not the least of which was our primary outcome was inpatient hospitalization, which was clearly impacted by changes in healthcare seeking behavior during the pandemic. But there were also some snafus along the way in terms of, because of the pandemic and the public health emergency, Benefits Data Trust was called upon to outreach around SNAP enrollment in a number of new ways that hadn't existed when we started our collaboration. And what ultimately ended up happening was we had a bit of a contamination challenge between folks who were outreached to through different concurrent campaigns that BDT was running, which made it challenging for us to create our outreach and comparison groups the way we had originally intended. So the good news was many more individuals were outreached to and ultimately enrolled in SNAP than would have otherwise had those campaigns not happened, which is really the outcome that we're very excited to share, that more people got access to nutritious food. We ended up having to modify our research design to not be able to look specifically at those that received the BDT outreach through this project, but ultimately just those who were enrolled and not enrolled in SNAP. So from a research perspective, that allowed us to have a greater sample size and more statistical power, but it did slightly change our original intention of the study. So I'm going to transition to Elaine there, and she's going to walk through some of the analysis and the findings that we came out with.
Thank you, Joan. As Joan mentioned, we have a little bit of a sitting down, looking at our data sets and asking ourselves, what can we do with the data we have? And this is, where we are at right now with our data analysis. We, again, to remind everyone, we were looking at dually eligible members who were eligible for both Medicaid and Medicare coverage. We look specifically from, as a payer from UPMC side, we look specifically for data from aligned members so that we can fully understand the cost of care, just because we have all the claims data from those members. The challenge was really, from the data we know some of our members who were receiving SNAP benefits. We were trying to create a comparison group who were similar enough to these members so that we can see how being enrolled to receive SNAP benefits changes their health outcomes. So we look into literature to see what variables we should match people on to create a comparison group. And following what the literature suggested, we matched a group using 1-to-2 matching, which means every person in the SNAP benefits group, we found 2 comparison members who were matched to this person on age, race, gender, comorbidities in terms of chronic conditions, as well as geographic locations using zip codes and area of deprivation index. So for the SNAP benefits group, we have about 661 members data. These members started enrolling for SNAP benefits in 2018 and onwards. We wanted to be quite rigorous in how we define this group of individuals who were receiving SNAP. So we consider how long would someone be receiving SNAP benefits. Can we expect a change in outcomes in terms of health utilization as well as some cost outcomes? Again, we look into the literature and seems like, it takes a while for someone to receive some nutritional benefits for outcomes to to change. And so in constructing this group, we were very deliberate in making sure that we look at members who were receiving at least 12 months of SNAP benefits to be included in our SNAP group. The comparison group was really people who were matched on these characteristics using 1-to-2 matching. And we had 1,320 individuals in the comparison group. I'm just going to flag that we will be presenting some bar graphs in upcoming slides. And whenever there's a blue bar, it's the SNAP benefit group. And whenever there's like orangey red bar, that's from our comparison group's data. So we thought we'll talk a little bit about who we included in the data set that we use for analysis. Just a note that all these variables I'm sharing were fully matched between between the comparison group and the SNAP group. So there were really no group differences in any of the characteristics. In terms of gender, the population we analyzed were 60% female and then 40% male. In terms of race, you can see that white population consists of 84% in the population, and Black and African American individuals with 13%. We have like missing data for some individuals, but you can see the split of the 2 majority group in our data sets. In terms of age, we have quite a widespread majority, as you can see, is 51 plus, and this is not uncommon given that we are looking at dually eligible population. So a lot of these individuals are dually eligible for Medicaid, Medicare. So that's why a lot of our of the member populations tended to be on the older side of the spectrum. And in terms of where these members live, again, majority in urban area and 19% in rural region. We were very diligent in comparing our comparison group and our SNAP group to make sure many of these, baseline characteristics were really not that different between the two groups. We do so just so we can isolate the effect of enrolling someone to receive SNAP benefits. And Joan mentioned the outcomes that were available to us. UPMC being a payer provider network, we have the opportunities to look at health utilization data from our EHR. So we have data on inpatient admissions for all these members. We have data on emergency room visits as well as unplanned care. So admission, for example, admission through emergency room or going to urgent care. We also have cost data on all these members. Oops, sorry. Cost data. We have cost data in terms of medical spending, pharmacy spending, as well as total cost of care. We have data from medical, pharmacy, vision, and dental that we constructed a total cost of care. So everything you can think of within for the care of any members. So those are the outcomes we compare between the two groups, SNAP group and comparison group. And first, let's take a look at what happened to health utilizations between the two groups. Really, SNAP enrollment versus non-SNAP group didn't really predict any of the inpatient visits data. You can see we look prospectively from the first year of a member being enrolled on SNAP, as well as second year as well. You see no star showing between the two bars, meaning that there were really no group differences in this comparison. We also looked at emergency room visits. Again, no group differences. SNAP group and comparison group had really pretty much similar emergency room visits. We also look at unplanned care use. Again, no group differences, pretty equivalent. That's health utilization outcomes. We also had the opportunity to look at some cost outcomes, and it's more interesting findings in the cost outcomes. As I mentioned, we have the capacity to construct something called total cost of care, considering medical, pharmacy, vision, and dental cost. What we found was that within the first year, the SNAP group had 16% less cost in terms of total cost of care compared to the non-SNAP group. These differences remain during year 2 of them being after enrolling in the SNAP program, which means that whatever savings happened sustained for another year. We drilled down to figure out what was really the cost driver for this group differences. And we look at two things. We looked at pharmacy cost and medical costs. What we found was pharmacy cost was really driving the group differences between the SNAP and non-SNAP group. As you can see, there's a group difference within year 1. Specifically, SNAP group incurred less pharmacy costs compared to a non-SNAP group. Again, that differences remain in year 2. Medical costs, we did the comparison. We didn't find any group differences. You can see a slight reduction in cost, but that didn't show up as significant. So that wasn't really the cost driver. That wasn't the underlying cost driver for what we found in the total cost of care. Another thing we drilled down on is what subpopulations of dually eligible members who were, benefiting from SNAP enrollment. Within dual eligible individuals, there were 2 subgroups. One subgroup is called the NFI subgroup. These are individuals who were not eligible for long-term care. And they are, they can independently manage their activities of daily living. They don't need home-based support. So they are the healthiest subgroup within the dual eligible populations. The other subgroup within dual eligible population is someone who's receiving supports to stay independent at home or community. So that's a relatively more dependent subgroup needing more supports. And when we looked at the two subgroups, and we found out that the more independent subgroup who were relatively healthier were the individuals who were showing a difference in their total cost of care. So as you can see, individuals who were within the subgroup who also were enrolled in SNAP had a lower total cost of care compared to the comparison group. So we within our team, we spent a lot of time discussing our findings. Earlier on, we presented that the literature suggests there are a lot of health utilization benefits when someone enroll for SNAP benefits. So far, what we found from our data was a reduction in total cost of care. That reduction persisted after 2 years. It seems like the reduction was driven by pharmacy cost. It was more apparent in the healthier subgroup of our dual eligible population. What we didn't find compared to existing literature is that reduction in health utilization, as well as reduction in medical costs that some previous studies demonstrated. We spent a lot of time thinking through our data, trying to understand what could be driving the inconsistent finding between our study and some of the reported data. One really big possibility was that all these cost data were collected during the pandemic, and we don't fully understand how pandemic changes health-seeking behaviors as well as healthcare costs yet. So, one possibility is because the study was situated within the time frame of the pandemic, that effect has not been easily parsed out in our data yet. And that's why we couldn't replicate some of the findings in existing literature. The other possibility is that the health utilization benefits from enrolling on SNAP, from receiving SNAP benefits, might take longer than the first 2 years to manifest in a person's health utilizations. So, in that sense, we really wanted to do a longer follow-up to see what happens down the road, maybe in year 3 as well as year 4 of someone after starting to receive SNAP benefits. So those are 2 directions we are thinking about, and we're certainly open to discussion and your thoughts on how we can tease out the impact of COVID, as well as how to look at our data in terms of understanding utilizations outcomes in members who were receiving SNAP benefits. So I think this is all we have prepared. So I'm going to actually pass it to Glenn to see if there's any questions coming in.
Fantastic. Excellent. Thank you so much for our team from Benefits Data Trust and UPMC. Really excellent work to hear about, and it does raise a number of questions. We do have some time for questions. So again, I encourage everybody, if you'd like to ask a question or make a comment, use the Q&A box down at the bottom center of your screen, type in your question, and we will get to as many of these as we can. So we do have a couple of questions already. First one asks about your what kind of explanation might you have for the finding that the SNAP enrollment reduced the pharmacy costs? What types of and do you have any information on what types of drug utilization patterns might have fallen after enrollment in SNAP?
Yeah, I can speak to that. We don't have data to fully explain, to fully answer that question well yet. What we've started exploring within our group was to see different subclasses of drug types within the pharmacy costs. So we were looking to do subgroup analysis for diabetic drugs, for example, drugs related to hypertension, metabolic conditions that we thought related to that would have like a mechanistic relations with receiving nutritional support. So we are doing some subgroup analysis and exploring that a little bit more. Right now, we're trying to come up with a collection of drug classes to look at within the claims data. And we, internal to UPMC, we do have a team who are very good with pharmacy costs. So we're tapping into that resources to help us understand our data. But that's a really good question. And it's certainly a question that we ask ourselves as well.
Yeah, that is a great question. You would naturally think about, whether there are any drugs that relate to conditions that might be sensitive to things like food insecurity. So we'll be eager to hear what you find from some of those, some of the subgroup analyses. Are there, particular patterns with regard to diet, like you mentioned, diabetes or hypertension or other metabolic conditions? That would be really, really interesting to see. So another question. Let's see. Question asking about enrollment in any other benefit programs besides SNAP. Do you have any information about what other programs may be, may be affecting the trajectories of some of these patient populations?
Yeah, I can take that one. So the way that BDT works in Pennsylvania specifically is screening anyone whom we connect with on the phone for multiple different benefit programs at the same time. A lot of them have eligibility criteria that are similar, and a lot of them also have separate applications for each benefit. So we try to, ask questions once and then take all that information and back end it to a bunch of different applications. Some programs that we helped members apply for other than SNAP were LIHEAP, which is a low-income heating assistance program that's available during a specific season, mostly the cold weather seasons, property tax and rent rebate. We also assist with Medicaid benefit recertification. We screen the entire household for different benefits as well. So if there was someone else in the household, perhaps eligible for WIC, maybe a pregnant person or a person with young children, we would screen and make that referral. Generally, there is not as much literature that we'd love to see it on access to these other programs and an associated reduction or impact on utilization or costs. I think it's well worth examining. Same with the Affordable Connectivity Program. That would be really interesting from a telehealth perspective if we can get more folks connected to broadband. I think it's also a little bit intuitive that more dollars in the household, through all of these different benefit support programs can help with overall health. How do you attribute I think the second part of it was, how do you attribute the total health cost reduction to just SNAP enrollment versus other programs? I'll let Joan and Elaine take that, but I think the conclusion was that we just focused on SNAP versus, or Lisa, please feel free to take it.
Yeah, I was going to ask Joan if we have a way yet within our data sharing agreement or otherwise to connect multiple different benefit programs.
Yeah, the other benefit programs data aren't specifically called out in our data use arrangement, but like Ashley said, I think increasing the overall household income, or sort of increasing the amount of dollars in that household's pie chart of spending frees up, or enables a family or a household to direct more funds toward healthcare, whether that's paying for a copay for a doctor's appointment, or paying for a prescription or something over the counter, or whatever it might be, or healthier fruits or vegetables. So that's kind of the approach that we've taken generally from UPMC side, in terms of thinking that it is an overall good to direct people into these types of supports, because there are studies saying, as the household budget shrinks, people do defer healthcare. They delay going, they make choices, they ration their medication, they make other potentially health adverse choices because the rent eats first, and there are other things that you just can't ignore, or you're going to have a crisis on your hands. So that was a long way of saying no. We haven't really been able to look objectively at those things yet, but it would be interesting if we could. I suspect there is some impact there.
What I'm hearing is that we need another grant to be able to answer this question and coordinating the data sharing agreement for multiple benefits a little bit better to be able to answer the question.
Yeah, it is a great question. It's given that your intervention is you're potentially linking folks to other programs beyond SNAP. Some of those currently unobserved, unmeasured linkages could also be helping to relax that household budget constraint, or be helping to contribute to some of the benefits that you're seeing in terms of cost reduction. So great point. More study needed. Fantastic. Again, folks have any other questions, feel free to type in. I'm going to ask a question about kind of big picture, based on the total cost reductions you see. Have you taken a look, done a back of the envelope calculation yet to be able to make an assessment of whether the cost reductions that the health plan is realizing through this program are large enough to pay for the program itself, to actually pay for the cost that BDT incurs in doing the linkage function?
Yeah, that's kind of the $1 million question, right? But outside of this study, UPMC is already contracting with Benefits Data Trust in an even larger initiative that involves our straight Medicaid members and enrollment in SNAP benefits. So even without a hard ROI number per se, we really see the value of it. I can't speak for our Medicaid team, which is probably doing that calculation of what the project budget in terms of return on those enrolled in SNAP might be, although that is something that we will definitely be looking at. But UPMC sees the value in that type of collaboration, and in the effort that we're already putting into partnering with BDT to get folks enrolled, even without that number hard and fast. So I don't know, Ashley, if you want to add anything to that.
Well, Ashley can feel free to chime in. And I see we've got a more general question about BDT and kind of where you operate. Are you serving are you providing this kind of service to other states, and in terms of connecting in the SNAP? So any more context you want to provide about BDT's work?
Hi, sorry, I just got a message from Ashley that Zoom just crashed, so I'm going to step in and answer this quickly. Yes, we are currently operating contact centers, which is the level of support that we are talking about here in Pennsylvania, where we have people available to answer the phones and help people apply for benefits in 7 different states at this point. And we also provide policy and technical assistance in a lot of other states, just to sort of help states do this kind of data matching on their own in order to determine who might be eligible for SNAP or WIC or any of those other benefits, and really assist those states in doing this kind of outreach themselves. Sorry, Ashley, did you want to? I see you're back. Did you want to jump in here? Did you hear the question?
I did, but I bet you answered it perfectly. So I can hear your answer.
Awesome. Thank you for that. Another question, just asking if you could say more about why the original planned randomization was not possible. Any more insight you want to provide on that?
Yeah, so I can go ahead and take that one too. So basically, this study happened, right? Joan kind of explained the timeline. The pandemic happened in the middle of it. The pandemic also triggered a huge period of growth in BDT generally. Like my position didn't exist pre the pandemic. I've only been on this project for 2 years because that's when I was hired. And our focus really became operational at that point. So as we were getting different requests from folks like, can you help us do outreach to this list? We think this, because unemployment was so high, like people were losing their jobs. People really, really needed this type of help in a way that we haven't seen in this country before. So basically what happened was this contamination that Joe talked about, where people received other types of outreach from other lists, which, as she said, was great in terms of getting people on more benefits, but detrimental to the research study eventually because, with different, essentially the treatment changed. And, I say this now as if it was some like decision. What are we going to do? Are we going to prioritize the research or the operations? And that it wasn't an active decision. Like this just happened. In the moment we were facing a huge need, and our focus has always been primarily on operations and doing outreach to folks. So we essentially just over outreach to this group, and our intended research design included instrumental variable analysis, which is why the randomization was important. We were going to use that in order to get a more precise causal estimate of the relationship between SNAP and these health outcomes, and that the level of contamination was just too much for us to really be sound in that approach methodologically, which is why we transitioned to the population study. I don't know if Joan or Elaine, you want to chime in on that?
That makes good sense. Thank you. So another question asking about COBRA, Medicaid, Medicare. I'll kind of interpret this question, I guess. To what extent would you see this model being exportable to people with other forms of insurance? Obviously, the nice thing about targeting dually eligible is that the income related, the means testing for Medicaid and for SNAP are pretty close. So you think there should be a large overlap. But could this be exportable to people with private insurance? Or just Medicare non-dual? Any thoughts there?
I can start, and I'd love to hear Joan's input as well. But yes, I mean, the main criteria really for eligibility for most of these programs is income, assets, and in some cases, household size. So we know that in certain areas, in certain states, Medicaid has not been expanded yet. So there are, and we know this for a fact, there are lots of folks who are on the individual marketplace plans, the ACA plans, who are eligible for SNAP or other benefits, but it is just, we can make assumptions about if they're receiving subsidies or not, and that gives us a sense of income bracket, so we can use that information to take a data-driven approach. So that's a huge opportunity. Partial duals or individuals on Medicare Advantage who are lower income, absolutely a huge opportunity there as well, especially in states that have higher income limits for SNAP. They actually differ between states, interestingly, despite it being a federal program. And again, it's really about finding ways to tie financial information to that, that insurance plan specifically. Basically all that to say, yes, lots of different insurance products or insurance plans that have people who are likely SNAP eligible. Also, another big one is senior prescriptions assistance programs. There's a very big one in Pennsylvania, one in New York City. That's something that Medicare Advantage and Medicare beneficiaries, original Medicare beneficiaries can absolutely look towards. So there's a lot of opportunity here, and a lot of the ways that any way we can take a more precise approach to it via data matching or understanding what data is available is a great way to find those people and try to connect with them.
Awesome. So we're going to get one more quick question related to that. Do we have any insight into why so many folks are eligible for SNAP but don't enroll, particularly among the dual eligible population you're dealing with.
Yeah, I can maybe we can go back to, or I know the recording and slides are being sent out, but there's a slide at the beginning showing kind of the main barriers. A big one is stigma that I don't think I definitely didn't understand when I first started to work for BDT. Yeah, here we go. This is perfect. Thank you, Elaine. The idea that you're taking dollars from your neighbor who might need it more, not knowing that the program exists, and not knowing that one might be eligible. There's confusion, especially for folks who have green cards or who have are different stages of the immigration process, what they're eligible for, what they're not. The application, if you've ever sat down and if you've applied for Medicare Advantage, some of the pain. If you absolutely apply for many of these other programs, it's difficult as well. Access to technology, big one for seniors, mobility and transportation to any offices. And yeah, there's just a lot of follow-up. Staying on these programs is hard as well. So the need to provide their data checks and documentation requirements that are kind of ongoing. As you might know, the public health emergency is likely ending in 2023, and that means that the Medicaid enrollment, the Medicaid disenrollment moratorium is over. It basically said that you can't get kicked off of Medicaid for failure to recertify, which usually folks need to do at least annually. And that's going to be a big focus, as well as documents. Can the state contact you? Do you have the right address? Do you know the next step? So those are a lot of different barriers I just went through.
Fantastic, really, really helpful. Well, thank you again so much for our research team from BDT and UPMC. Great work here. For anybody who may want to follow up with a research team, you can find the contact information for this team on the Systems for Action website, systemsforaction.org. We'll also post a recording of this webinar and slides up on that site for folks who may want to review later. And again, if you want more information about Systems for Action Research Program, feel free to contact us as well. Our National Program Office contact information is up on the website as well. Thanks to everyone. Hopefully you'll join us. We do this every 2 weeks. Join us next time for another update on research on how to align medical, social, and public health systems. Thanks so much, everybody. So long.